to assimilate and every
Yes,
time and just
yes,
confusing at times. Yeah.
exactly, exactly.
Well, we should probably get started.
Sure.
I just want to introduce and thank you. So this is Dr. Naik from Metabolism, Endocrinology, Nutrition, based out of South Lake Union, who has been an advisor on all things telemedicine, especially during COVID. I've sat in on some of your talks. They've been wonderful. And I really appreciate you coming to talk to our group to help us continue to get more efficient and more competent in this really important technology that we'll be using forever.
Yeah, I guess so. Thank you.
Yeah. Thanks so much.
Okay. Yeah, thanks for the introduction, Grant, and good evening, everyone. And I appreciate you all making time in the evening hours to participate in this session. So the whole thing emanated discussion between Brad Annewalt and I a couple to 3 months ago, because we have our endocrinology diabetes weekly meeting during this lockdown period. And then we were trying to figure out how best we can integrate the telemedicine practice when we suddenly, all of us, including you all, had to switch from in-person visits to telemedicine. And what I did during that whole process was trying to work on different ways. How can we improve the efficiency of conducting these visits? Because initially it was overwhelming to anybody just to switch 100% to telemedicine, and a lot of nuances to be navigated. And so what we thought was, I kept looking into and exploring various options and come up with some strategies, which I kept sharing with endocrine division. Then Brad said that, why don't we just disseminate it within Department of Medicine? I did a presentation, couple presentations actually, with pulmonary critical care, and also cardiology was interested. And then the rheumatology, you people showed some interest. I thought it's a good idea to share some of the best practice and also learn from your experiences and see how we can leverage the available technology, which is evolving, or rather which has evolved significantly from the time we began doing telemedicine visits. And so again, just a quick disclaimer that this is not a compliance or billing talk, and guidance and educational initiatives run by EPIC teams, telehealth team, clinical informatics teams. Again, so this is more of informal sharing of views. And also the challenges now, we are going back to a hybrid model of integrating telemedicine with in-person, how best we can do going forward. So my talk, I'm focusing first on the E&M level selection. That's the most important component of telemedicine documentation, because all the billing and the payments are all driven by how we capture our visits and how do we document it. And then I would walk you through the infrastructure limitations and how best to use the technology. For example, when we initially began, we started using phone visits before the telemedicine actually kicked in. And the challenge was, how do we mask our home phones or cell phones while doing the telemedicine visits from our home, for example. And then I'm sure you people also must be using the Doximity video and phone calling facility, how we integrate when the Zoom doesn't work, and how do we integrate the EPIC with Zoom, and over the course of time. I mean, actually the telemedicine and clinical informatics and EPIC's team have brought so many new technologies into place thanks to COVID pandemic, and been trying to integrate all of them. This is a very standard thing, which I'm sure you're all familiar with. This was an interim final rule, came back on 4/30/2020 during this public health emergency by CMS. And this is basically taken directly from Ruth Perkins compliance emails that came to us back in the month of end of April, early May. So basically what we do here, we use the CPT codes of 99201 to 205 for new patients and 212 to 215 for the return visits. And again, you're all familiar with adding a GT modifier or the GC modifier for the teaching situations. And again, we all have been practicing. I think it's a bit of a mute discussion right now because we have come so many months into this telemedicine. There is nothing new here. Location of the patient, location of physician and APP. And in the case of teaching, physician location of an attending and also the residents, and all persons have to be identified at the originating and distant site. Then we need to state that the service is performed via live interactive audiovisual equipment, and telephone visit codes are basically 441 to 99443 depending on the time duration. It's entirely time based, and we don't need to add any GT or GC modifiers here. So one of the important things that needs to be kept in mind, if one is actually billing these telemedicine visits based upon the MDM complexity, I think it's a good idea to add a start time and stop time, document it. But if one is billing it only on the basis of the time-based services, I think one could just mention that I spent so much amount of time on this particular visit or this particular consultation. And of course, the name of all participants, and if we are using alternative platforms other than the University of Washington HIPAA Zoom, it's expected to explicitly say what platform are we using and if whether or not it is HIPAA compliant, for example, Doximity. But again, to be frank, I'm not sure if we're all following exactly. Let's say if we switch to a Doximity call, whether we're actually doing it or not, I'm not sure. But this is something that's what the guidelines clearly states. Now, this is a very familiar interface that you all have dealt with. Open the patient visit and then click on connect and you come online, and that's pretty standard. And the way we have been trying to use adding this blurbs of distance side telemedicine encounter, you are using a template of your own. You just add this particular language into it and you just pull the template and it automatically populates. That's what I do it for the telemedicine visit. But if not, you just put .eltel, it automatically brings up all these options, and then you can choose whatever the most appropriate. The most common is telephone visit or site telemedicine visit when the patient is at his or her home with somebody and you are remote or in the clinic, whatever. And there is also originating site telemedicine visit wherein the patient is actually in a hospital facility and you are remote, but that situation is relatively less common. So we use this and then fill in all this information. And again, there is literally not significant difference as far as history elicitation is concerned and E&M or medical complexity decision making is concerned, but physical exam, obviously we can't do it comprehensively. So I just showed an example what one could assess and capture. It's entirely specialty specific, and it is just putting together some kind of observations that all of us have been already doing. So there is nothing really new. I'm sure you have been doing all these things. So again, going back to a little bit on the interim final rule for telemedicine, as I said, unlike the regular face-to-face visits, the entire billing is based upon the MDM based medical decision making complexity and the time based, where it is important to note that the time is all the time that is associated with evaluation and management on the day of the encounter. This is an important thing because earlier, whenever we have billed based upon the time component, we always had to say counseling and or coordination of the care constitutes 50% of the time of the component for the billing purpose, and that requirement is not applicable in case of telemedicine. We don't need to have 50% of the component for coordination and counseling, but we can count all the time that it takes a pre-charting review of the patient reports before the telemedicine visit and afterwards completing the notes and charts. All these can be included here, and if that time constitutes whatever that time is, that will be used for billing if you are going by time-based. I mean, to be frank, I'm almost 90% in telemedicine visits going by time-based billing because you anyway spend the allocated time, including the time you spend before and after the actual patient encounter. And same way, for example, this is how we capture. I mean, one thing is you basically could add some of these favorites. For example, I have added telemedicine here, and in diabetes, we do the continuous glucose monitoring reviews. We use a special code 25 or a teaching code that we need to add for telemedicine or teaching modifiers. You can pull it and save them under modifiers here. You can use this button to actually add them. And similarly, I added the phone visits of 10 minutes, 20 minutes, and 30 minutes so that it makes it a lot easier to choose what you want to go for. As I said, if you are doing a time-based billing where you don't need to document 50% of the time is spent on counseling and coordination of care, I think it is expected that one would add a sentence saying that I spent 50 minutes on the patient's care today, for example, or I spent 50 minutes on the patient's care today, including pre and post time, if you want to be even more specific, and include the teaching physician documentation when working with a resident and make it clear that the time does not include the resident time, and what time we state here is entirely the time we attendings spend. I think that's an important thing to keep in mind while doing the time-based billing. Now with medical students have returned to the clinic, and this is again a material that came from the compliance department, even though it's appreciated that medical students get involved in the telemedicine visits and it's important part of the learning, but given the complexities of the billing based on medical student documentation, it is not allowed currently that medical student documentation should be used for billing purposes. So even though they are encouraged to participate in the visits with us, but as far as billing is concerned, it's entirely the time or the involvement of hours that needs to be captured, and medical students time or assessment is not factored in telemedicine billing related activities. So this is some of the quick recap, which all of you are familiar. Maybe 1 or 2 points might be new, but this is what it is. We are all doing it for the last several months. Now, what I want to highlight primarily is I would walk you through how the things evolved. When in the month of, I would say, mid-March or so, we suddenly switched from in-person visits to telemedicine. The first thing we did was switching to a phone visits for the couple weeks or so before the telemedicine actually became effective. So one of the challenge when we were all doing from home was how do we mask our phone numbers from our cell phones or the home numbers when we are doing the telemedicine. At that time, I'm not sure how many of you are using it. University of Washington has a caller ID feature from the telecom department, and if you have not subscribed, still you can call them and get this set up. So basically you register whatever phone numbers that you want to use, whether it is your cell phone or home phone or multiple phones with them, and one would dial 206-520-8899 and wait for the dial tone. It automatically allows you to enter the patient's name, patient's number without having to enter your number and codes if you have already registered, and the person will see the phone is coming from University of Washington, whatever number you have put it, and this came very handy when we began. In addition to the Doximity dialer, I don't know, quite a few of you must be using or members of Doximity, and one could use the Doximity dialer. I mean, you can save University of Washington number or whatever your clinic number is as a calling ID, and you just enter the patient's number here and call using the phone call. And more importantly, when you go to Epic on the phone app of Haiku and click on patient's mobile number or cell, whatever number that the patient's preferred number is, it automatically cascades into Doximity, and then it shows as if the phone is coming from University of Washington Medicine, Diabetes Center, or whatever your clinic is, and the patient would perceive that way. This, and along with the University of Washington Medicine caller ID feature, came very handy when the telemedicine practice began. Then came the video visits. Since I'm on the Doximity screen here, then the Doximity introduced within very quickly actually the beta version of video calling. So the challenge of Haiku, the challenge of I would say Zoom was a lot of patients had skepticism or difficulty or their own reservations of downloading a Zoom app and trying to use Zoom for the video conference. At that time, Doximity came very handy. So if you have a phone Haiku app, you go to Doximity, you basically click on the patient. I will come to that when I come to the video visit. You can directly click the video call with Doximity and actually conduct the video visit. I actually do it very often. Many a times, we are on Zoom call and we are waiting for the patient. They don't show up or you don't see them. I call them and ask them what's happening. Are you having any trouble coming online? I mean, there could be various reasons. They don't have a computer, or they just don't want to download, or they are struggling with technology or whatever. Then I would say, look, let's try an alternative way. There is also a secure physician telemedicine option. I would send you a text message which comes from a generic number that says my name here. You just accept couple buttons and you are come online. And this has worked significant number of times. So the advantage of using this is when we are stressed or challenged with Zoom-based telemedicine visit, instead of ending up with a phone visit, one could still do a synchronous audiovisual consultation with Doximity, and it could still be, and it's HIPAA compliant, and it is actually been approved by University of Washington's clinical informatics department as an option. But again, they don't encourage Doximity use so much, but it is a backup option. And I think probably 20 to 25% of the times I actually end up doing Doximity with my phone for the video call. And if one wants to do it from a computer, as long as there is a camera on the computer, we can have the Doximity video on the computer screen as well, in addition to the phone, and do exactly the same thing. So this has really come handy in terms of technological challenges that we face. Then came in the month of April, when we started doing all these telemedicine visits. At least I live on the east side. The biggest challenge was all these Amazon, Microsoft, and Google guys working from home in the neighborhood. The bandwidth of internet connectivity was extremely slow. It was almost impossible to continue a meaningful conversation with a patient on a telemedicine visit because the internet is slow and the screen gets frozen and it gets hung up. Then I tried to think, what do we do here? I figured out that one could actually download a Citrix app on the phone. So similar to Haiku app on the Epic Haiku on the phone, your cell phone, you can also download a Citrix Workspace, which is important for telemedicine visits. And once you download it, what I started doing at that time was I forgot the computer. I started doing telemedicine visit entirely with my cell phone, wherein I would turn off the Wi-Fi connection on the phone because internet is slow, and I just use my cell phone signals. And when you click on it and you log in, you exactly say this interface on the workspace. And I think the UW Medicine IT people can help set up this access if you want. But again, today it is somewhat superfluous. I don't think it's required. And I'm talking about using this before one could do telemedicine visits on the cell phone. This was in the month of April, where a Haiku app was not integrated with telemedicine capabilities. So at that time, you just click on Epic and you will see exactly the same interface as what you would see on your computer. You click on it and you are online and you can use whatever virtual background you want to use. So this came handy for a few days when there was a big challenge of internet connectivity at home and using computer was a big problem. Then our clinical informatics group introduced how do we integrate Epic and Zoom on 2 devices. This was the next important step in facilitating telemedicine visits in a better fashion. So when we began, we had started with our standard Zoom accounts of University of Washington. Then we got the HIPAA account installed. Initially, it was all fine because you just log into Zoom separately and Epic is separate. They are dissociated. It has some advantages in the sense that you could see the next patient coming into your waiting room, even if you are not finished with the previous patient, and you could send a message, tell them that I'm with other patient, and you didn't have to log back in and log out every time with a new patient. That was a part. But then when the integration happened, that became a bit of a challenge. But this slide, what I wanted to highlight was how do we join with a smartphone and tablet and Zoom with a computer. So once you have, I mean, this is particularly important when we were struggling with a shortage of cameras, because suddenly our clinics had to get cameras to do the telemedicine visits, and there was a national shortage of cameras. We didn't have enough rooms with cameras when we wanted to go back to clinic and start doing some of these Zoom visits. Then what we did at that time point was we used this functionality that the Epic team introduced. We would connect on our computer in the offices and connect Zoom without a camera. And then either you can copy paste the invite and send it to yourself and open it on your cell phone Zoom app and come online. So you are online on your phone with a video and on the computer with the audio and the Epic chart in front of you. Or alternatively, one could send yourself a zip whip kind of a message like what we do for the patients, for those who do not active on the e-care portal, and then again come back on your cell phone. So basically you started doing consultations using the cell phone for the video call on the Zoom app, and that signing into our own meetings with the patient and using the computer for rest of the things. This was again some sort of intermediary step because of the shortage of the cameras, and if you want to use both the things, because again this was at a time where our cell phones could not be used for the complete telemedicine visits, where there was no integration of Zoom and Epic on the Haiku app to do the video calls. Then the most important development that happened, I think probably the Epic team introduced sometime in May, if I remember correctly, with the Haiku app. I don't know how many of you are using it. I use it extensively. You use the phone app of Haiku or on the Canto app on the tablets. Then you come here on the screen, you will see the appointments if you have any on that, and you can search the patients. You have a secure chat functionality available in basket access. For those who have been using Haiku app, I think you are very familiar with this. Now, if you scroll down at the bottom screen here, all the way to the rightmost end, you will see the telemedicine icon. This functionality got introduced in the month of, I think, May or so. This made a big difference in facilitating telemedicine visits from home or wherever you are, and without having to depend on the internet connectivity and bandwidth and all those things. You just do the cellular signals and do it. When you come here, you click on it, you click on Zoom, and you are automatically on a Zoom video call, and you are on your computer with an Epic chart, and then you just navigate both. And actually, I've been using this as my primary mode of doing the telemedicine visit these days. I don't really, now that is a hybrid model, we had to go to the clinic. I don't really care about finding a room with a camera attached to the computer. I just take any room, open the Epic with, tap the badge and open the Epic and just use my phone and then dial in and just use back and forth. Only thing you can't do with this is you can't screen share with the patients because your Zoom call is with a phone and your Epic chart is on the computer. So it's a bit of a disadvantage, but it adds significant degree of flexibility. And I found this as at this time is the best option that I found. Then came the problem when Epic and Zoom were totally dissociated in the beginning period of telemedicine visits. It was easy. You just log into your Zoom account. Patients are coming into waiting room. You just send a message that I am still with the previous patient. The patients were kept all the time informed without having been lost as to what's happening. But now with the integrated version, you need to call in and log out multiple times. It's a bit of a challenge. So I tried to use this feature. If by any means you are able to log in and greet, patient can allow the patient to join the waiting room, you can customize the waiting room by saying that you have entered this person's waiting room, you put your picture here, you just make a message that you are running late with a different patient, please wait with patience. So this made things easy because patients were getting lost. They say that they're calling in, they're seeing the spinning screen with nobody, your host will allow you to enter the meeting, they don't know. Now I think things have improved because people are getting used to it. But in the initial days, it was a big challenge. People will just hang up and then you go on Zoom, you don't find anybody, you try to call them. It was a big mess. I'm sure you all have experienced that. So this functionality of customizing your Zoom waiting room, this is one of the Zoom settings. You go and make this whole changes. And if you are able to, you're seeing a patient in one room, next room, you just go and log in and put this on. And the patient who calls in for a video call would see this screen, and then they know that, okay, they are actually in the patient's, in the doctor's waiting room or in the clinic. So they don't get apprehensive as to they're lost somewhere. There is also a functionality. You could actually use HIPAA University of Washington Zoom, and if you have linked your accounts, you can actually see all the patients listed here, because unlike pre-integration time where the Epic and Zoom were dissociated, everybody would use one single meeting ID of yours. But now every patient has a different meeting ID. So with a one screen, you can actually start and end the meetings, but not a big advantage. It's just a feature I just wanted to show, but I don't really use it these days. I just start and end the meeting with every patient as we go along. And this is just a functionality that makes some degree of help, but nothing major, I would say. And thanks to, again, COVID pandemic with telemedicine innovation, what happened was we are all, I mean, I am kind of one of the older folks. My typing speed is very slow and I can't really type very fast. So I heavily depend upon dictations. So I was always struggling, how do we do the dictation, because we can't have the Dragon microphone at home. And that was a big problem. Otherwise, you had to just call the University of Washington transcription line and make the dictation, not the most ideal one. But thankfully, our Epic team and clinical informatics team introduced this power microphone nuance app on the phone. And this, I'm sure most of you have used it. You click on the DMO login, you see this kind of a bar, and then you sync with your phone, any computer, anywhere. You can just start dictating it. This has become a major advantage in terms of those who use the dictation option. You could be just using any computer and or any device wherein you can just do the dictation using the power microphone from the nuance. Another thing I started using of late, which the Epic team introduced sometime in June timeframe, was using the phone app for dictations, which is different from this. What happens is once the patient has checked in, you open your notes here, for example, and type in .dict, these two options you will see, you click the first one, dictate later, it creates a space here, partial dictation added by you, then you close the app, then in your in basket on your phone app, Haiku, you will see all the list of dictation that you need to do. Then you can just click on the microphone. You don't need to sync with the computer, unlike the power microphone of Nuance, where you need to sync your phone with the computer to dictate, which we do it in the clinic all the time. Here, you could be walking in the hallways, you could be sitting in your office, you don't, and I do it very often. At the end of the day, I just send every dictation, my notes, to the Haiku app. I mean, I'm not not very efficient to finish everything by the end of the day. I just bring work home and I sit and just open the mobile app and use my scribbled notes on the paper and keep dictating, and it automatically gets into your notes on the patient chart, and then you sign in and just close it. I mean, again, everybody's style is different. This is one of the options that you can use if you are heavily dependent upon dictations. So these are some of the technological things that we learned as we went along from the month of March, April, May, and June. And we kept adopting and we kept sharing these practices within endocrine division, which I would say fairly techno-savvy. I'm sure other divisions also, you might have used it, but I just thought of sharing all these things, what we did. Maybe it was not really relevant, you're already knowing it, but I just thought we'll share these things. And before I conclude, a few other things. Of course, there are additional resources. You have read this listened to 0 to 60 Learning Lab from Angad Singh's videos, compliance website related information. For example, the UW Medicine compliance has all these information that is available. You can always go back and refer to those things. And Epic Earth discussion forums talk a lot about these things. But now the key question is, how do we go about now? Because now that we have got a hybrid model, we have intermix of telemedicine and in-person visits. These days we are dealing with the last couple months. It's been a challenge, to be frank. There is no ideal way. I mean, still we are doing 30-40% telemedicine and rest is in-person visits, like you all are doing it. So what I have been trying, and some of the other providers in endocrinology are doing, everybody has different style. I try to segregate telemedicine from in-person. For example, first half of the day you want to do telemedicine, or second half in person, for example. Or I try to dedicate one whole day only for the telemedicine visits and the other 2-3 days for the in-person visits. But that's not happening, unfortunately, because it's very hard to juggle for the front desk and the PSS team to segregate these visits. But the best what I found was I would like to do the telemedicine visits in the beginning of the day where the things are under my control. The problem is when you have a couple of in-person visits, there is a usual clinic lag of 15-20 minutes. The patients are roomed, the vitals are taken, and in diabetes, the technology stuff is downloaded. By the time I get into the room, 20 minutes are passed, and in next 10 minutes, next person is a telemedicine visit. It's a big stress. I can't be on time, and it takes 15-20 minutes of delay. And unless the person is well informed by MA, or I just call them and tell that I'm running late, it's always a big problem. So I try to do the telemedicine in the beginning of the day or just immediate post-lunch sessions. So the things are under my control and things are not delayed. But some of the providers prefer to do telemedicine at the end of the day. Again, it's everybody's preference. And the ideal would be that rooming by medical assistants, I don't know if it is happening in rheumatology. We are still struggling with the bandwidth and resource constraints in endocrinology and diabetes. If you are dealing with an in-person visit in the clinic and the next room, the MAs can start the visit virtually as a co-host and greet the patient, try to collect the medication information and do the med reconciliation and put them in the waiting room. Then it is the best option to do. The hybrid model can work very well, but we are not being able to adopt that as yet. But that's is one of the ways to go forward, because we have to all live with telemedicine going forward. It is going to exist. And rest of the things I've already discussed. And let me stop here. Actually, we are on 30 minutes time. So let me stop, and I would like to hear what your thoughts are and what your experiences, any learnings from rheumatology that we should be aware of.
Well, I had a question sort of about the communication from UW to the patients about telemedicine, like with appointment reminders and original. So, I've been doing quite a bit of telemedicine recently, and some of the things that you went over, as time has gone by, the technology has gotten better, et cetera. But there still seems to be a lot of problem with patients connecting on Epic, but not on the phone when they're doing Zoom on Epic. That there's often a problem with pop-up blockers. They have to allow pop-up blockers. That seems to be a big issue. I have figured out a variety of things that they can't get on, and I know how to copy an invite and send them another. So if I have a patient who's having difficulty getting on, I will try a few things. I'll copy an invite. I'll send it to them by eCare. At the same time, I'll pull up ZipWhip and I'll send them a message on ZipWhip with with a copy of the link to get into the Zoom room. Eventually, I may call them, although I haven't been doing the Doximity video. That was a fabulous tip, because oftentimes by that point, I'm converting to a telephone visit. But I'm wondering if we as Department of Medicine, or hopefully more, if there's something that could be done a little better beforehand with the communications to the patients, figuring out who has done the Zooms before so they don't need that much and who doesn't. So I wondered if you could tell us what you know that's being done and the communications, and whether we as a group have any suggestions to bring forward if it's not being done.
Yeah, I agree with you, Julie, because this is certainly the most important thing, because this is the major stumbling block that we all run into. To be frank, I mean, what we do is, at least the PSS or the front desk team at the diabetes clinic where I'm primarily based, they try to do all those things, and they put in the appointment list in the comment. They say that the patient was reached out, patient has difficulty, do a phone visit. There are some comments, so always look into the comment section. When I look at my appointment list in Epic, I always try to focus on if our front desk people have put any comments about patients' technological challenges. We tell them that just specifically ask if they can do it or they can't do it. Sometimes the patients are in nursing homes or in assisted living facilities. That's another big challenge. I mean, they don't have a phone, or they have it, but the nurse has to come or somebody has to participate. That's another big mess. But if everything, and at least in diabetes, what we do is we have been telling our medical assistant to reach out to patient 2-3 days in advance so that they can send all their continuous glucose monitoring and pump data to us, so that we have it already scanned into the media before we talk to them. So that's a part. But despite all the efforts, we still run into the challenges. And to be frank, I feel that we trying to do this zip whip thing and sending the messages, it drains so much of our energy and resources. Half the time goes by the time we even start the consultation. Out of 30 minutes, 15 minutes, 20 minutes is gone. I come online, patient, I expect them to be online in 5 minutes. If I don't see them, I just call them using the Doximity or the phone line and ask them what's going on. They say majority of the time, they say that they can't get on, they could not download the app, whatever the reason is. Then I will immediately switch to Doximity. Literally in 30 seconds, they see on the phone the message coming, they click on it, they come on the video, and I continue the conversation on the Doximity. I would say that's the best thing to do without wasting time. I mean, a lot of our colleagues in endocrinology are doing that actually. They're using the Doximity stuff.
Yeah. Do you have a sense, I'm seeing in, like, say, the Kidney Stone Center.
Yeah.
I noticed that if you look in the encounters from the Kidney Stone Center, that they have something we can see. You know, there's a patient e-care message that goes out from them a few days in advance, and it'll say, you have a telemedicine appointment coming up with Dr. Cormack, and blah, 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 blah. And then it also has the links that they can look at the telemed things about how to do it, etc. Has there been, I don't believe that we are I know we are not doing that in our clinic. And so I wondered if there's any data about something more formal like that. Are the
yeah,
groups
it is
that
actually, I believe our clinic staff are doing that. I mean, they reach out to the patient 2-3 days in advance and send them the the Zoom link and how to log in and all the information. I can check on it specifically with our PSS staff tomorrow and ask and find out what exactly they send the patients. But I know for sure that that team reaches out to the patients well in advance, and they clearly send all the information. And those who are not on e-care, they try to encourage them. I mean, they encourage them to set up the e-care. If not, they send a zip whip message to them and try their best actually. But despite all that, it still doesn't work all the time. But I can certainly look into that.
I don't want to monopolize the Q&A. The last thing on this piece is that, do you know if there's an attempt for it to be coordinated with the patient reminders? Because that also seems to be an issue, that they'll say, oh, you have an appointment, and they can't tell if it's at the clinic or not. And it's also a communication time that if we knew what was being communicated when, maybe it's either a time that we reinforce something important, like take your, pop-up blockers off, or we, contact 1, we give X information, contact 2 as a system, we give the next. I guess if I had so I wonder if there's any integration that you know of.
Yes, to my knowledge, our front desk staff do send the reminders, and they tell them exactly whether it is a telemedicine visit, or it's just a phone call, or it's an in-person visit. And they do integrate this information about the telemedicine with them. But I'm not sure they go to the extent of telling, make sure that you turn off the pop-up blockers and some of the technology glitches the patients might run into. I'm not very sure about that part. So what I can do is I will have a conversation tomorrow in the clinic with our staff and ask them what efforts are being done at least in the diabetes clinic. And I'm happy to share with your group, certainly. But again, I know it's the most ideal thing to integrate this across various divisions in all the clinics that we practice, a standardized way of doing the things. But unfortunately, that's not happening. Yeah.
Yeah, the appointment reminders for our clinic don't come from our clinic. So That's, how about you, Grant? Appointment reminders, is there some other system that does it for you? Yeah, you're unmuted now.
Yeah. No, I think we use a similar, it's automated system, so it doesn't have a lot of capacity to assess people's competency or ability to use telemedicine. It's been an ongoing issue.
Okay, Grant, have you been using the Doximity stuff or not yet?
Not the voice. I use the phone, the dialer, and the fax services.
But not the video one.
Not the video, but I might do that because we do have to bail out on a certain percentage of telemedicine, and it would be nice to maintain that video connection and obviously the billing, the revenue of telemedicine.
Of the division, yeah, absolutely. Okay, yeah, Julie, I will definitely look into these and see what they're doing it, because I know for sure that the diabetes team are calling the patients about some of these reminders and Zoom integration related information, but how detailed is it and how effective, I can definitely look into that and share that experience. Yeah. Any other questions or comments?
I have a question on billing. You had talked about being able to bill on total time spent.
Yes.
Is that true for any insurance, or is that just for Medicare?
I think for any insurance, I've been billing it for any insurance, and it has always, no questions have been asked so far. And when I look at our RVU monthly statement generated, it has never been a question so far. It's been like 4 or 5 months we're doing it, because the big challenge is, one more thing I think I didn't mention, what I heard from folks that the coders are actually looking at every encounter in telemedicine and reviewing them, that if it meets all the criteria that needs to be met. And if it is based upon medical decision-making, MDM complexity, they say that you don't need to explicitly write that you are basing your code. You just choose whatever level you want to bill at, and they will just glance through your notes and come to conclusion. I don't know how they do it, but whatever. I mean, they do it and they're supposed to endorse it or downgrade it or whatever, if it is MDM based. But if it is time based, you need to explicitly state how many minutes you spent, and it is very clearly stated in the CMS. And I think all other insurances are also using it in addition to Medicare, that if you spend 50, 60, whatever time minutes, that includes pre and post time, that's all included in billing. So I would say 90% of the times in telemedicine visits, I'm just doing it by time based. I'm not really bothering about the MDM stuff here, unlike in an in-person visit.
Okay, that's really good to know.
Yeah.
I'll try doing that myself.
Because in an in-person clinic, basically in a follow-up visit, if you want to bill 215, you need high complexity, a comprehensive history and a complex medical decision making, and the physical exam could be very minimal or problem focused. It still captures, because the issue is if you are spending 20 minutes of time and you are billing level 5, you need to document it in terms of that you are really using the medical decision making complexity of the highest order and have taken a comprehensive history or physical, 2 out of the 3 have to be met in a in-person visit. Whereas in a telemedicine, physical exam is almost nil, and it becomes really challenging unless it's very obvious complexity. I actually prefer just doing it by the time there, and it has always worked.
Okay, good tip. Thank you.
Yeah, and by the way, in 2021 January, the new CMS rules that are going to come, that's another thing that we will be focusing soon in terms of our presentations, is we don't, that new billing is entirely based upon MDM or time, that's all. There is no billing, there is no requirement of documenting the extent of history and physical exam in the new system that's going to be implemented effective January. All the
Boy.
billing is going to happen, at least in the outpatient, is entirely on MDM or the time-based, not on physical and history. That's going to be a major change. They just
Yeah.
mentioned that it needs to be medically or clinically appropriate history and physical exam, but whole weightage and emphasis is on MDM. So I think that becomes really key issue going forward next year, that capturing MDM complexity becomes a key component of our evaluation, not so much on history and physical exam, and trying to fill those bullet points of 10 or 20 or whatever systems that we need to always meet. You just put the template and do that, but that's not really required going forward.
Like a reasonable change.
It will be a reasonable change. I assume it will be good. And because right now we always try to pull the last visit notes and try to update it and put it, they say that you just need to update the history from the previous assessment till today and don't need to repeat whatever is said in the previous note. You just say that rest of the information go back to the previous note. And that's all we need to do in the history. And whatever clinically appropriate physical exam, and the whole focus and discussion is on the MDM. So that's going to be rolled out, and I'm sure the billing and compliance folks will start scheduling some education sessions for everyone in the fall of this year.
Oh, thank you.
Yeah, thank you.
Here's a quick question about the state of Washington, or a state that you're licensed to practice in. I notice in Swedish, they have different templates like we do of our dot phrases that are made by folks. And, most of theirs like focus on that I clarified that the patient was in the state of Washington, I'm wondering, how important that is and what other people have done. I have found a number of times where people live in West Seattle, but they've been camping and they're prior to the fires were in Oregon, or people flew down to their Palm Desert place and, and you're already committed. There's a lot of UW resources that are committed to you sitting there 10 minutes into this visit. And I just wonder what others are doing and if it's a hard and fast rule. And
no, I think based on what in one of these billing and compliance guidance from the compliance department was if you could be doing telemedicine, if it is your patient, you've already seen the patient, it's not as it. If it is your own follow-up patients and they are in from an state, I think it is perfectly fine. And I think I don't offhand remember, but at least some neighboring states, neighboring in the sense Alaska, and also I think Idaho and Montana, 3 or 4 states, you could do telemedicine even for the new patients, and it is permitted according to the current rules. Again, these rules were laid out in the context of public health emergency of COVID, but whether or not they are going to persist, I do not know. And I have done telemedicine visits, somebody calling from Florida, or because he had seen me, and somebody has got a home in Arizona or somewhere, Phoenix. So I have done those things, and people from Alaska is not very uncommon. I mean, I had handful of patients doing telemedicine from Alaska, and Oregon is very common. So if they have been a patient of your practice and you have already seen them, and at the time of telemedicine, they are somewhere in the country, it's fine. But if it is a new patient, I don't offhand remember, but some states it is permitted. And again, these are currently permitted under the public health emergency. And I don't know whether it's going to continue beyond a point. I think once I sent an email to the compliance department about a particular case, but I don't often remember, but they said it is okay to do so. That's what they wrote. But I didn't really ask specifically what states are permitted if it is a new patient that you're doing a telemedicine visit for.
yeah, I was mainly thinking of follow-up patients. Yeah, thank you.
Yeah. And also other thing I was surprised to see, because initially when I created the template for telemedicine visits for Epic Notes, I always say that due to the COVID-19 pandemic related reason, the telemedicine visit is being conducted, etc. But if you currently go and try to put the dot phrase of dot tele, and then you pull the telemedicine visit thing blurb there, it doesn't say COVID at all. That means I asked actually specifically the compliance department why this verbiage of COVID has been removed. They said it's not required. So if you are just pulling the dot phrase, you don't need to put extra efforts to put that COVID sentence there in telemedicine visit. You could do telemedicine without related to COVID. That's what the current template says. They say that, yeah, it's a good idea to put that sentence if you want to, but it's not a requirement currently. That was a bit surprising to me. I mean, I didn't know that, but one of the times, sometimes you think that patient is coming in there and you just pull your template for in-person visit and it happens to be a telemedicine. Instead of changing, I just add that dot phrase and just do it. Just add that one sentence. Or the most common scenario is you have seen the patient in person 3 months ago and it's an in-person visit. The patient comes back as a telemedicine today. And instead of creating, I just pull my old notes, add this telemedicine dot phrase, fill in the requirement. There is no COVID there. And I just delete the physical exam findings and just replace it with whatever minimum what I could do on the telemedicine visit, and just rest everything remain the same. And you just edit that notes. That's what I've been doing it for people going back and forth, one visit in person and the next visit is telemedicine. I think this dot phrase has really been come very handy.
Dr. Naik, again, Phil Moberg, I'm one of the Northwest rheumatologists, despite what my moniker said, that's my wife's computer. I want to just ask the group in general, thank you for the presentation, it's great, learned a lot. We've been doing some things right and some things not so right, so it's good to hear where we can fix stuff. I just want to know if the groups, is anyone hearing back from compliance officers about things that haven't worked? Because, you know, I think everybody's probably been doing stuff slightly, and I haven't heard anything negatives, and so I just assumed it's all positive and that the billing's going through and it's okay, and it may be that we're sort of in a pandemic state and we're going to get things through. So tightening everything up as you've suggested with the documentation. But has anyone gotten any negative feedback from compliance and billing? I haven't. So I just, if anyone has.
I have not, although I have sometimes forgotten to put a GT modifier, and they will say, you know, was this done as telemedicine? Please, you know, put that on, or vice versa, that I had the dot phrase for telemedicine, but it actually, the person changed and came into clinic because they wanted their knee injected or something. And I had prepped their chart as a telemedicine and I didn't take it off, and so they've caught, you know, given me little reminders and had me fix it to the right type, GT or not, but I haven't surprisingly had a billing issue.
So it sounds like they're at least looking at the doc. My suspicion was that it was just all going through and they're just throwing their hands up and we're just hoping that insurance was going to pay and not worry about it. But it sounds like they are taking some looks at it, which is good to hear.
At least mine.
Yeah.
Yeah, I think I heard the same thing actually from the pulmonary, when I did this presentation and discussion. Rob Glennie from Pulmonary Critical Care, he said that every telemedicine notes are being reviewed by the coding group, billing and coding folks. They're reading everything, because I haven't had any. Only in the beginning I had just one comment from the billing department that I forgot to put the time for a telephone visit. I just put it as 21 to 30 minutes, that kind of a thing, 99 whatever 431. But then they said that no, you need to explicitly say how many minutes you actually spent, and they downgraded it to 10 minutes, the level 1 actually at that time. And this was in the beginning. Phone visits were not paid commensurate with the time you spent, but currently I think the phone visits are paid comparable to in-person visits of the corresponding time spent. Yeah, they're paying more for the phone visits now.
Oh.
That's what our understanding was as well, yeah.
I had another question for the group. If somebody shut me up if I'm taking all the time. I just wondered if anybody had, for the screen shares with the patients, I've done x-rays and I've done labs, but I haven't done any patient education stuff. And I just wondered if anybody had any other things that they've found the screen share helpful for, and if so, how do you do it?
I have done the screen share multiple times in diabetes clinic, because we basically, same way you click on share the screen, And then the most common thing we use it in diabetes endocrinology is using the data from the pump information, insulin pump data, and the continuous glucose monitoring download. I will go over the graphs and statistics and explain to them. And if sometimes patient is little techno savvy and if they want to show their blood glucose chart on their computer, I will give right to share, and then they share the screen, and then I can clearly see, rather than they rattling, my morning sugar was this and afternoon was 120, and I keep jotting down. If that is already on the computer in an Excel sheet, quite a few patients do it. I do that. And sometimes if I'm discussing the lab results, serial renal profiles or A1C values I want to show them, I will just screen share and open the results tab and just show them, and then and stop the sharing the moment the work is done. So it has worked well. I don't say that I use it all the time, but I've used it probably 40% of the visits. It has worked well.
Any of the rheumatologists doing any patient education things, or showing them how to do an exercise, or it's obviously very hard to be showing a piriformis stretch or something to them on the video, but anybody doing patient education stuff or any tricks there?
Just ad hoc stuff. I mean, I'll pull stuff up on Google and show, research papers or random things like that, but nothing on a regular basis.
No, I haven't done any either. But I do want to see you demonstrate a piriformis stretch. So
yeah.
It's the advantage of having your patients for so many years that there we have a comfort level. So I'm like, yeah, I actually was able to do it in my office, but I had to get way back up against our sliding doors. But I didn't fall over, so that was good.